All right, so now let's talk about AV nodal reentry tachycardia. And the thing with AV nodal reentry tachycardia is the mechanism in which it occurs. And this is one of the times where adenosine works.
A cutaway view of the conduction system shows an impulse initiated in the sinoatrial, or SA node, that spreads to both atria and then activates the atrioventricular, or AV node. From there, the impulse passes down the left and right bundles of the ventricles. The split screen shows normal sinus rhythm on the left. On the right, an AV nodal re-entry pathway is shown, in which the AV node becomes rapidly restimulated, and the ventricular response is rapid.
So the conduction that's causing the ventricle conduction is all occurring at the AV node. This is a re-entry mechanism here.
The corresponding rhythm strip shows a regular, narrow, rapid QRS complex. The rate is rapid because the AV node is re-stimulated cyclically. The QRS is narrow because the impulse travels normally down the left and right bundles of the ventricles. The external view shows a normal sinus rhythm on the left compared with a supraventricular tachycardia on the right, with the ventricle beating rapidly at regular intervals. Note the re-entry circuit around the AV node that enables it to be stimulated at such a rapid rate. Provided that the patient is stable, a first-line treatment option could be adenosine, which is given via intravenous push. The initial adult dose is 6 milligrams. Adenosine has a very rapid half-life and must reach the central circulation rapidly in order to be effective. This patient's blood pressure is normal. Adenosine acts on the AV node to block conduction. Note that in doing so, there is a brief period of asystole. The re-entry circuit was also blocked by adenosine, allowing for the resumption of normal sinus rhythm.
Is that too dark? All right. So using some of these pictures right here, all right, so I'm going to kind of read what they have right here. All right, suppose water were traveling down two separate channels. One of the channels is smooth and the water travels by laminar flow. So laminar flow, so that means that it's just a smooth flow. Okay, there's no turbulence in it or anything like that, no friction or anything like that. So what would be faster? Which flow is going to be faster?
Laminar.
The laminar, right? Because there's nothing that's blocking it, nothing that's restricting it. The other channel is traversed with rocks and boulders leading to the formation of turbulence. All right? So, laminar flow is faster because the water does not have anything holding it back or obstructing the flow. All the water is heading in the same direction. The friction only occurs along the sides where the water touches the channels. In turbulent flow, the water is constantly crashing into and around obstructions, which essentially slows the flow, which is this right here, right? All right? So, now, let's apply that concept to a real-life model. Suppose that you have a system of dry river channels, like the one here, okay? The main channel splits into two branches that are exactly the same, with the exception that one of the channels has some obstructions, which would cause turbulent flow if the water were flowing through it. So, where they're going here is kind of, they're trying to show you the concept of reentry, like we talked about last week. So, in place of electricity, they're using flow and the left side is going to be a slow conduction pathway, where the right is going to be a fast conduction pathway. So let's say that the electricity or the water comes through, the dam's open, the water comes through. They're both trying to get here, right? What's going to happen? Which one's going to get there quicker?
Right.
The right side. All right. All right, so first the water would travel by laminar flow until a branching point of the two channels. Then the water would proceed down the two branches like we just talked about. The smooth channel would continue to transport the water by direct laminar flow, and the water would travel very quickly. So this is going to be the fast channel, like I just said. The fast channel. The obstructed channel will begin to develop turbulent flow as water winds its way slowly around the rocks. So this would be the slow channel. Now, what would happen when the water that traveled down the fast channel reaches the shallow, dry pond bed? The pond would begin to fill very quickly. Note that the pond is filling while water is still winding its way down the slow channel. What happens when the pond is completely filled? Where's the water going to go if this side has not reached all the way? All right, there you go. So now it's going to start going back up. All right. The two wavefronts would travel along the slow channel until they crashed into each other. At that point, the water would stabilize and the water level would equilibrate according to the amount of water entering the system. All right. So in this case, just like with electricity, the fast channel comes down, stimulates, the slow channel still going down, but then they merge into each other, creating a cloud of smoke. Well, it's not a real cloud of smoke. You had to be here. Right? So there you go. So the sequence of events is fairly intuitive and easy to understand. So that's what happens when, in the normal cycle of many patients with dual approaches to the AV node, you've got your slow channel and your fast channel, and they end up causing each other to fizzle out. Okay. There the two currents meet, essentially canceling each other out. Note that the depolarization wave traveling down the fast pathway depolarizes the AV node. So this occurs in 99.99999% of the time. But now the 0.00001% of the time, which is very rare but very real scenario, leads to the formation of a re-entry circuit within the AV node and to the formation of AV nodal re-entry. All right? So, in this case, I didn't put the tree picture in here. Or did they have it? Nope, they didn't. All right, so in this case, though, all right, so we saw what happened there, all right? So suppose the tree washed down by the rapid flow of the flash flood, and the tree propped itself right across the fast channel. What will happen to the flow of water then? Well, what you would end up having is that this is going to end up coming down and filling up, but then it's going to go back up, and we're just going to catch there, right? So now we're only filled by the water here, and we're going to continue filling until we start having issues, right? Because this is blocked off, there's nothing to equilibrate. Oh, there it is. Yeah, so that's where it's going to fill up before that does, all right? So I know that this is a little botched, but let's keep going. The water would then fill the pond and flow retrograde up the fast channel until it reached the bifurcation. All right? When the retrograde impulse reaches the bifurcation area, the area where the tree would be, it would find the slow track ready to receive the impulse again, and a re-entry circuit is born. all right? So instead of both of these coming down and equilibrating, we're going to go up and it's just going to continue to feel, all right? Causing turbulence and causing issues, all right? So, with the AV node, with your dual pathways like we talked about earlier, you got your fast and your slow that approach this. And so, sometimes you're going to have a topic pathway that causes what we just talked about with that reentry circuit. All right? So, an atrial depolarization wave is approaching the AV junctional tracts. So we had something up here, atrial depolarization, and it's going to come here. What's supposed to happen? The fast is supposed to come down, stimulate. The slow, they're supposed to meet up, right? The depolarization wave travels down the fast channel faster. The result is that the AV node is depolarized by the impulse from the fast channel. The impulse then begins to spread backwards from the AV node to the slow channel. Eventually, the two wavefronts traveling through the slow channel would meet and cancel each other out in a cloud of smoke. Well, not a real cloud of smoke. Now, that only one of the impulses was transmitted to the ventricles. All right. So now, depending on which tract transmits the impulse, the PR intervals will vary. The variation can occur beat to beat in many circumstances. All right, so with this picture right here, a normal sinus depolarization wave arrives at the two tracts. The fast tract transmits the impulse as expected, but then you have a premature impulse that occurs right after the sinus. So instead of having that period of time for this to come back up and to go out, now I've got an ectopic area that now has formed, and it's sending it down here, and the fast is catching up there, then the slow, all right? The premature impulse will then arrive, and this sequence is shown here, okay? By the time the PAC arrives at the two tracts, the fast tract is refractory, and the impulse must proceed through the slow tract. When the impulse reaches the AV node, it begins to fire retrogradely through the now refractory fast tract. And then PAC triggers a circus movement or circular movement involving both tracts of the AV node. The resulting reentry circuit leads to the formation of a rhythm known as AV nodal reentry tachycardia. Note the pseudo S pattern at the end of the Avnrt complex is representing the retrogradely conducted P wave. And you may not always see that. As a matter of fact, you really don't see it very well in this example right here. I wouldn't expect you to see that. All right? If you see that and you say, hey, that just looks like a S wave, sharp S wave, I'm going to say, okay, that looks like a sharp S wave to me too. What I'm looking at is the fact that you've got a fast complex, okay? Now, if you think about it, what's our treatment for our tachyarrhythmia? Like our narrow complex tachyarrhythmia, our initial treatment. Adenosine. So adenosine, 6 milligrams, a rapid IV push, followed by 12. All right. So adenosine slows conduction at the AV node. Okay. So what's happening here is that now we've got this very fast cyclic conduction that, remember, every time it goes here, I can't really see. Every time it hits here, it's going to the ventricles. Every time it hits here, it's going to the atria, right? So the ventricles are going to respond to whatever comes this way, right? So we're going to give the adenosine, hopefully, to hit the AV node so that this will slow and then stop, and the SA node can fire, and then we can get back into a normal progression. All right? Adenosine mainly works with Avnrt. And when we think about SVT, Avnrt is usually what we think of textbook. SVT. All right, narrow complex, rates really fast, and all that, okay? So rates are typically going to be 50 to 250, or 150 to 250. P waves can be varied. Typically, we're not going to see a P wave because it's going so fast, okay? It should be regular. Your P wave shouldn't, you probably won't see them. If there is a P wave, it's going to be inverted PR. If you usually can get a PR. Your QRS is going to be normal, should be. Grouping should be normal. It all should, everything should be there. There should be no drop beats or anything like that, okay? So typically this is an idiopathic cause, but when somebody starts experiencing this, they may have several episodes in their lifespan, and they may end up having to either get some type of ablation, or they are on a beta blocker the rest of their life, or something like that, to keep this from happening, okay? What do? When we see this rhythm, we look at their perfusion status, right? Remember your tachycardia algorithm, right? You go down, you say, okay, is this causing anything in the pink box of death? Is it causing anything that is shock-like or poor perfusion-like? If the answer is yes, then we got to determine, is it narrow or wide, because that's going to affect our cardioversion joules, right? But if the answer is yes to the pink box of death, our immediate treatment's what? It was taking a left on it, synchronized cardioversion. All right, so this is a narrow regular, so we're going to go 50 to 100 joules, at least on the Zoll monitor. All right, 50 to 100 joules. Okay, if the answer is no, if you've got a heart rate this fast, you're still probably going to have some palpitations, probably still going to have some fluttering and all that, but your blood pressure is good. You're anxious, but your mental status, you're still responding to me appropriately and all that. Then I can answer no to the pink box of death, and now I've got to determine, is it a wide complex or a narrow complex, because that's going to determine what drug I'm going to give. My first drug would be, well, the first thing I would do is not a drug, is what? Vagal maneuvers. You can get them to bear down against closed glottis like they're having a bowel movement, get them to cough forcefully. One thing is get a syringe, get them to blow in it, tell them to focus on the plunger, see if they can blow the plunger out. That creates a back pressure that causes vagal stimulus. And sometimes that may work. If that doesn't work, or they're refractory to that treatment, then we go to adenosine. Adenosine is supposed to block the AV conduction, hopefully reset that conduction pathway. If that doesn't work, then we can move on down. For rate control, we can try our beta blockers. In the tachycardia algorithm, they use sotalol. Sotalol is a class 3 antiarrhythmic and a beta blocker. If y'all haven't gotten to your classes of antiarrhythmics yet, so it's in the same class of mechanism of action as amiodarone is. Amiodarone, though, is a different drug. They will still work for your arrhythmias the same way. But you could also maybe do like labetalol or some other type of emergency beta blocker to help with rate control. Or cardizem. Cardizem actually has some AV nodal blocking agent properties as well. Cardizem is your calcium channel blocker. And one thing you've got to be very, very careful with calcium channel blockers is that they cause systematic hypotension or systemic hypotension. So they can make their blood pressure drop really quickly. All right? So you have to be careful with your dosing with that, especially with the older patients. Okay? But if they are hemodynamically unstable, then we're going to shock them first. All right? So this one here, we got a rate of what? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 180. No P wave, no PRI. QRS is narrow, about 0.08 or so. So this would be an AV nodal reentry tachycardia. You can call this supraventricular tachycardia on your quiz. All right? Because honestly, there's really no way to determine the difference in this situation as entry level, as doing what we need to do. We're going to see this, we're going to treat it just like we would any other narrow complex tachycardia. All right? Now, what may happen if this is not a narrow complex, or if this is not an AV nodal reentry tachycardia, when we give the adenosine, what we may see is it flutter down, but not convert, because adenosine is still going to slow the conduction pathway, and then we might see it speed right back up. And then we may try cardiazine or something like that. All right? Now, in this case, you've got this pseudo S wave right here. You can kind of see it where it's got that indentation there. All right, this is a really fast rate. 190. If they are stable with this, they're not going to be stable for a real long time. This is an example of the pseudo R wave where it kind of notches right there, really fast rate. That's 180, but they didn't even give us a full thing, so it's probably over 200. And we could actually do a R to R to get it exact if we wanted to. All right, let's just look at a couple more and then we're going to move on. Again, just a fast rate. We see a prominent T wave. We see QRSs that look the same, no P wave. We're calling this, the tachyarrhythmia. Okay. All right. So there's still a bunch of practice ones here. This one is about the classic one that what you would think of here. It does have a little bit of a deep S wave there that goes on up into a T wave. This one too, but let's see what they say. This is not the P wave. That's the T wave. That is a small S wave that could be considered a pseudo S wave there. It goes into the T wave. Nothing there. All right. Yes. Y'all good? Y'all see it? All right. All right, so that's AV nodal reentry tachycardia. All right, so in your